Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts. I am Dr. Sreenivas, neurologist from Andhra Pradesh, India. Today I am going to talk about very interesting concepts. The concepts of third nerve, fourth nerve, sixth nerve, supranuclear gaze palsy and internuclear ophthalmoplegia. These concepts appear intimidating, challenging, but once you understand it becomes really exciting. So we shall discuss the concepts of third nerve, fourth nerve, sixth nerve, supranuclear gaze palsy, internuclear gaze palsy and multiple ocular nerve palsies. So third nerve, the important concepts are, there are about 4 important concepts of third nerve palsy. The first thing is that the third nerve, there is a central subnucleus which supplies both the levator palpebrae superioris. So a central subnucleus of the third nerve in the midbrain supplies both the levator palpebrae superioris, and therefore when there is a lesion in the midbrain, the central subnucleus gets affected and person will have bilateral ptosis. So if a person has got bilateral ptosis, it is a nuclear third nerve palsy that is in the midbrain. But once it comes peripherally, there could be a unilateral ptosis on that side of the lesion. But a central nucleus in the midbrain, a third nerve palsy, will cause bilateral ptosis because both the levator palpebrae superioris are supplied by the nerves coming from a central subnucleus. So central subnuclear third nerve palsy will cause bilateral ptosis, right? And second concept is that the superior rectus is supplied by the contralateral third nerve nucleus, not the ipsilateral third nerve nucleus. So the superior rectus is supplied by the contralateral third nerve nucleus, that is in the midbrain. So if my left third nerve nucleus gets affected, it is not the left superior rectus but the right superior rectus which gets affected, and person will have superior rectus palsy. The second concept. The third concept to be known in the third nerve palsy is that the parasympathetic fibers run superficially on the third nerve. The parasympathetic fibers run superficially on the third nerve. If there is a third nerve palsy, there are 4 Ds. 1. The pupillary parasympathetic fibers get affected. So instead of pupillary constriction, there will be pupillary dilatation. So dilatation of the pupil. Because the levator palpebrae superioris, which is supplied by the third nerve, gets affected, there will be ptosis, that is drooping of the eyelid. Because the third nerve gets affected, sixth nerve will overact. So there will be lateral rectus overacting, and therefore there will be divergent squint, and because of that, double vision. So what are all the features of third nerve palsies? Easy to remember, there are 4 Ds. Dilatation of the pupil, drooping of the eyelid, divergent squint and double vision. So when there is a compressive lesion of the third nerve like posterior communicating artery aneurysm, the superficially placed parasympathetic fibers get affected. And therefore, instead of constriction, there is dilatation of the pupil. Whereas, if it's an intrinsic third nerve palsy like diabetes mellitus, it affects the center of the nerve, and therefore there will be other manifestations of the third nerve like drooping of the eyelid, divergent squint and double vision, but pupils will be spared. So in diabetic third nerve palsy or ischemic third nerve palsy, pupils are spared. Whereas in the compressive third nerve lesions, the pupils are the first to get affected. Third concept. Fourth important concept of third nerve is that aberrant regeneration. Whenever third nerve gets affected, there is aberrant regeneration of the third nerve. But this aberrant regeneration of the third nerve is seen only with compressive lesions like tumor or trauma. It is not seen with the ischemic lesions. Because when there is an ischemic lesion and a third nerve palsy, slowly the third nerve will get recovered because eventually there is good blood supply to the third nerve, and therefore the third nerve maintains its integrity. It goes on a simplified straight track. But it is a compressive lesion, a traumatic lesion. What happens when the third nerve regenerates? the sprouting fibers get misdirected. So instead of supplying pupillary fibers, they may supply levator palpebrae superioris, or instead of supplying levator palpebrae superioris, they may supply the inferior rectus. So there is aberrant regeneration of the third nerve when there is a compressive lesion like trauma. Because of the miswiring of the sprouting fibers, there could be a cross connection between the levator palpebrae superioris and pupil. So whenever they try to elevate the eyelid, the pupil may constrict, or whenever they try to elevate the pupil, levator palpebrae superioris, the same nerve fiber may go and supply the inferior rectus, and therefore eye may look downwards. So this is known as aberrant regeneration. An important point is that aberrant regeneration is seen only at traumatic lesions or compressive lesions, but not ischemic lesions. Ischemia, the tract is maintained and therefore they do not produce aberrant regeneration. And usually the ischemic nerve palsies, especially the third nerve palsy, usually recover after a few weeks. So aberrant regeneration is not seen in ischemic third nerve palsy. It is seen only in compressive lesions. So these are all the important concepts of the third nerve. Now let's check out on the fourth nerve. The important concept of the fourth nerve is that the fourth nerve exits dorsally. This is the only cranial nerve exiting dorsally. It exits dorsally and crosses over, and therefore supplies the superior oblique on the opposite side. So fourth nerve supplies the superior oblique on the opposite side. So if fourth nerve nucleus is involved, the superior oblique on the opposite side is involved. The action of superior oblique is to intort and then to depress. So its primary action is to intort. So imagine if my right superior oblique gets affected, I can't intort. So to compensate that, I tilt my head to the opposite side. So when I tilt my head to the opposite side, I can compensate for the intorsion, and therefore the vertical diplopia becomes better. But when there is intorsion and I tilt my head onto the same side, the vertical diplopia worsens. Because superior oblique causes intorsion, and since I am not able to intort because of superior oblique palsy, I can intort or tilt my head to the opposite side, compensating for the intorsion of the superior oblique, and therefore the vertical diplopia comes down. So this is known as an important head tilt sign. So the moment you see a person coming with a head tilt, always suspect a fourth nerve palsy, right? Now sixth nerve, again there are two important concepts here. Sixth nerve nucleus has got two neurons. One, the neuron supplying the lateral rectus on the same side. Second, the abducent nerve nucleus has got interneurons which cross over to the opposite side through the MLF, supplies the medial rectus. So abducent nucleus has got two components. One, the neuron supplying the lateral rectus on the same side. Second, the interneurons crossing over to the opposite side through MLF goes and supplies the medial rectus. So when my abducent nucleus gets stimulated, there will be gaze, horizontal gaze towards its side. Lateral rectus on the same side through MLF medial rectus on the opposite side. So if abducent nucleus is stimulated, there will be gaze. But if only the sixth nerve fascicle gets stimulated, there will be only lateral rectus action and only there will be abduction. So a nuclear stimulation produces a horizontal gaze, whereas a sixth nerve fascicle stimulates only lateral rectus and there will be movement only on the one side, that is abduction. So very classic examples is the Fowey syndrome and Milliard-Gubler syndrome. In Fowey syndrome, the sixth nerve nucleus gets affected and therefore there will be horizontal gaze palsy, seventh nerve involvement and hemiplegia on the opposite side. So in Fowey syndrome, it's a sixth nerve nucleus which gets affected. So there will be horizontal gaze palsy, seventh nerve palsy on the same side and hemiplegia on the opposite side. But whereas if we take another example, Milliard-Gubler syndrome, it affects only the sixth nerve fascicle along with the seventh nerve and corticospinal tract. So unlike Fowey syndrome, Milliard-Gubler syndrome produces only abduction palsy. It is not a horizontal gaze palsy. So in Milliard-Gubler lesion, there is only sixth nerve fascicle palsy and therefore there is only lateral rectus involvement, only abduction involvement with other components, seventh nerve palsy and contralateral hemiplegia. So the important differentiating point between the fovea syndrome and Milliard-Gubler syndrome is that in fovea syndrome it's a horizontal gaze palsy, whereas in Milliard-Gubler it is a sixth nerve fascicle palsy, and therefore only abduction is involved. Fine. Another important point of sixth nerve is that it is usually involved in a raised intracranial tension. It is known as a false localizing sign. Why false localizing sign? The localizing sign is not because of the compression at that particular point of interest. The lesion may be somewhere else, but the manifestation is at a different place. So you call this as false localizing sign. Raised intracranial tension usually produces a sixth nerve palsy. A raised intracranial tension usually produces sixth nerve palsy as a false localizing sign. Why? It is presumed that whenever there is raised intracranial tension, there is a rostrocaudal displacement of the brainstem because of the excessive pressure. So what happens is brainstem goes and impinges. The sixth nerve comes from the pons and then goes over the clivus, then pierces the dura and enters the cavernous sinus. So the clivus bone, if it is like this, the clivus bone is like this, the sixth nerve goes over the clivus and then pierces dura and enters the cavernous sinus. So when there is raised intracranial tension, the brainstem goes and impinges on the sixth nerve over to the clivus, and therefore the sixth nerve gets compressed because of the pressure and the brainstem onto the clivus. So usually sixth nerve palsy is produced in raised intracranial tension as a false localizing sign because of the rostrocaudal displacement of the brainstem and impingement of the brainstem onto the sixth cranial nerve, which is on the clivus. Right. So these are the important concepts of the third nerve, fourth nerve, sixth nerve. So can third and fourth and sixth nerve involve together? Can there be a combination of multiple ocular motor nerve palsies? Yes, whenever they are close together, they can get involved. One is in the cavernous sinus, where 3, 4, 6 are present in the cavernous sinus or superorbital fissure or orbital apex. Second, in cancerous conditions like carcinomatous meningitis or carcinoma producing autoantibodies causing Lambert-Eaton syndrome, or myasthenia gravis, where the multiple nerves can get affected, or giant cell arteritis, where again multiple nerves can get affected, or the Miller-Fisher variant of Guillain-Barré syndrome, where the 3 and 4, 6 nerves can get affected. So these are the important concepts of individual cranial nerves: ocular, trochlear, abducent, and there are few conditions which can cause the multiple ocular nerve palsies. Now, supranuclear gaze palsy. What is the supranuclear gaze palsy? Whenever you approach a person suffering from ophthalmoplegia, it could be either a supranuclear involvement or internuclear involvement or infranuclear involvement. The nuclei in question of eye movements are 3, 4 and 6. So if the pathway is like saccadic pathway and pursuit pathway supplying these 3, 4, 6 nerves are involved, you call that as a supranuclear gaze palsy. The 3, 4, 6 nerves are interconnected together through MLF, medial longitudinal fasciculus. Because of the interconnection of 3, 4, 6 through MLF, I can use eyes in various combinations: right lateral rectus, left medial rectus, right lateral rectus, left lateral rectus, both right medial rectus and left medial rectus. All these combinations are possible because of the third, fourth and sixth nerves being joined together, acting together through medial longitudinal fasciculus. So if there is a lesion in MLF, you call that as internuclear ophthalmoplegia. Then the third is infranuclear pathology. As I said, if individual third nerve, fourth nerve or sixth nerve get affected, you call that as infranuclear palsies. Now, when you approach a person with ophthalmoplegia, the question arises, how do you differentiate whether it's a supranuclear gaze palsy or infranuclear involvement? Supranuclear gaze palsy. So what is supranuclear gaze? The eyes move together. So when I need to look to the right, my left frontal eye field's area number 8 gets stimulated and my eyes looks towards the right through PPRF in the pons. So it's the saccadic pathway descends in the left frontal eye fields, area number 8, midbrain pons, it crosses over and goes to the PPRF. PPRF connects with the sixth nerve on the same side through MLF, the third nerve on the opposite side. So when my left frontal cortex is stimulated, my eyes will turn to the right. This is known as saccadic pathway. The pursuit pathway is the following movement, slow eye movements. For that also the center is PPRF, where the pursuit pathway comes from the parietal lobe on the same side, goes to the PPRF. So whatever may be the gaze, whether a horizontal gaze because of saccades or horizontal gaze because of pursuit, the final pathway is PPRF. So supranuclear gaze palsy, it implies that the 3, 4, 6 nerves are intact, but the pathways like saccadic pathway is affected. So in that case, they'll have gaze palsy. They cannot move eyes together to the right when my left frontal eye fields area number 8 is involved. So how do you know whether it is supranuclear gaze palsy and infranuclear gaze palsy? Intranuclear palsies. Supranuclear gaze palsies. So when you give a command or instruction, they cannot move the eyes towards the right side when there is a supranuclear gaze palsy. But the 3, 4, 6 nerves are intact. So you can make the eyes move towards the opposite side by stimulating the vestibular apparatus. You call that as oculocephalic maneuver or vestibulo-cochlear reflex. What is vestibulo-cochlear reflex? When you stimulate the vestibular apparatus on, in this case, left side, the eyes will move towards the right side because of connection through to third nerve medial rectus and to sixth nerve on the opposite side. So when the vestibular apparatus is stimulated, the eyes will move towards the opposite side. This is to maintain the fovea, the image exactly on the fovea, on the macula. Otherwise, if I turn my head and my eyes also moves along with the head, then the image appears blurred. So when I turn my head to left side, my eyes have to move to the right side. This is known as vestibulo-ocular reflex or oculocephalic maneuver or doll's eye reflex. So when I have gaze palsy, supranuclear gaze palsy, when I am not able to move my eyes from the left to the right, when I stimulate the vestibular apparatus, vestibulo-ocular reflex, it moves the eyes towards the opposite side because the nerves are intact, indirectly implying that it is a supranuclear gaze palsy. So supranuclear gaze palsy can be overcome by vestibular stimulation or oculocephalic maneuver or doll's eye maneuver. Whereas if it is 3, 4, 6 nerves per se are involved, even if I stimulate my vestibule, it cannot move because per se the 3, 4, 6 nerves are involved. So in supranuclear gaze palsy, by vestibular stimulation, you can overcome the gaze deficit and you can move the eyes. Whereas if it is an intranuclear ocular nerves are involved, you cannot move the eyes, however the vestibular stimulation may be. This is one point. The second important concept is that it's a gaze palsy. Either the eyes move together or the eyes do not move together, and therefore double vision or diplopia is not seen with supranuclear gaze palsy. So in supranuclear palsy, double vision or diplopia are not seen because they move either together or they do move together. So the images coming from the two eyes are exactly focused on the same macula, on the same area of the macula, corresponding areas on the same macula. Same eye and the fellow eye goes on to the same corresponding parts of the macula, and therefore there is no double vision because it's a gaze palsy. Whereas if it is a sixth nerve or third nerve palsy, you will have double vision. Suppose if it is right lateral rectus palsy, when I look to the right, the double vision increases because the images do not fall on the same point, on the same corresponding point of the macula. So double vision is seen in infranuclear ocular involvement. Double vision is not seen in supranuclear gaze palsy. Supranuclear gaze palsy can be overcome by vestibular stimulation or oculocephalic maneuver or doll's eye movement. Intranuclear involvement cannot be overcome. Right. Now coming to the internuclear ophthalmoplegia, as I said, the sixth nerve on the same side is connected to the third nerve on the opposite side through MLF. So if there is a lesion of MLF, the medial rectus gets affected and therefore adduction gets affected. So to compensate that, you have, because of Herring's law of equal and dual innervation, the corresponding abducting muscle lateral rectus will produce nystagmus because of overcompensation. So if there is INO in the pons, what you call as posterior INO, the adduction gets affected. But since midbrain is intact, the conjugation, the convergence is intact. So in pons or pontine lesion, which you call as posterior INO, the convergence is spared. But if it extends to rostral region and midbrain is also involved, what you call as anterior INO, even the convergence gets affected. So by looking at the convergence, you can differentiate whether it's anterior INO or posterior INO. In anterior INO, convergence is also affected. In posterior INO, convergence is not affected. So this is in nutshell the overall overview of the ocular nerves, the supranuclear gaze palsy and the internuclear gaze palsy. I've enjoyed giving this lecture and I hope you have also enjoyed listening to the lecture. If you have any doubts, questions, suggestions, kindly post your comments to my YouTube channel. And please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.